So today is going to be our last class in renal. This is exciting because the more systems we do, the easier it becomes with the time. So like for example, cardiovascular must have been the most difficult. Renal is also not easy subject. We are doing actually hard subjects so far. Pathology, it was not easy. Immunology, which is the next subject, is not easy as well. But here is the thing. We finished the bulky subjects first, which means that the subject that will come after that will be a bit easier, except of CNS, to be truthful, but regardless of CNS, the other subjects are much more easier than this one. So I would like first of all to answer one inquiry of one of you guys who asked, well, how can I know the normal results on the exam? So let me show you this thing. This is normally I show for people in a little bit advanced stage, but let me show you this. So there is something called the free 120. Please, for now you are still in the beginning. Do not open it yet. So this free 120 is basically the company that makes the exam, the NBME. It also makes this mock test. Basically, these tests are exactly like your real exam, in which you can practice the format of the exam. So if I start one of them here, you will see that how exactly the exam looks like. By the way, guys, can you tell me if you can hear me and you can see my screen? Yes, great. Okay, so as you can see in this, please do not read what is written because you will have to do it later. But the idea is that your exam screen will look exactly like this, okay? So you will have here the ability to look at the labs, see? So he was the person that was asking, well, how can I know normal values? How can I know the normal values for the USMLE? Maybe they will be different from one place to other, you know? So the answer is quite easy. You can just, in the exam, go to the lab values and find all of them here, okay? So no need to stress yourself about that. Everything you need is located here. But just to go over some stuff, I just want to show you the following. So here you can, okay, see the electrolyte here? This is your inquiry. The question was like, what is a normal potassium level, sodium level, chloride level, and other electrolyte for the USMLE? You don't have to memorize that. You know, memorization is not for the USMLE, basically. So they will give it to you on the test. You just open the labs and take a look at them. That's it. So you are like, okay, what about creatinine? Here it is. What about PUN? Here it is. So you don't have actually to look up anything, to memorize any values. All of the values will be given to you. So we are clear on that point, so we can go back to our renal. So speaking about cancers of the kidney, if you remember in pathology, we spoke about cancer in general, and then I told you for each system, we will speak about its cancers. Well, guys, we spoke about cancers in the heart. Can you remind me what was the most common type of cancer of the heart? Yes, we will have a review time today, yes. Exactly, metastasis, which is most likely melanoma. Excellent, good. So, and then what is the most common pediatric tumor of the heart except of metastasis? Okay, yeah, it's rhabdomyoma. What about adults? Okay, good. So now we are going to speak about renal cell carcinoma. This cancer is super important. Why it's important? Because of something called Paraneoblastic Syndrome that we'll speak about in a moment. Do not worry about it now. So renal cell carcinoma. Let's start with the name. Renal cell carcinoma. What does carcinoma mean? It's a cancer of what? If we say carcinoma, first of all, it's a cancer of epithelial cell or mesenchyme? Tell me, please. Is it epithelial cell or mesenchyme? Carcinoma. So please know that when we speak about carcinoma, where are you guys? Yes, that's you. So when we speak about carcinoma, it is epithelium. But when we speak about sarcoma, it is mesenchyme. Okay? So that's the difference between them. So now we are speaking about renal cell carcinoma. So it must be epithelial cells. Okay? So let's take a look. They write polygonal clear cells. Clear cells means that there is nothing inside of them. They look clear from the inside. So actually, let's take a deeper look at them. Renal cell carcinoma. So you are asking what is the difference between epithelium and mesenchyme? Yes, okay, good. So the epithelium is basically a type of cells that you have in your body which mostly cover your inner organs. For example, they like to say that the human body is an upside down balloon. Let me explain what that means. So, do we have epithelium in our skin? The answer is yes. So you have epithelium in our skin. And then what about your oral cavity? You do have that as well. Okay, what about all of your GIT? Yes, you have epithelium all over your GIT. From the mouth until the anus, you have epithelium. And this upside balloon thing, which means that basically they like to imagine the human being as a circle and it has a tube like this. And from around the circle, it's all epithelium around it, which is the skin. And all of the GI also has epithelium from the inside of it. And epithelium, the word epithelium means like something that covers, okay? So you can find it in the urinary tract. You can find it in the GIT. You can find it at different portions. So look here. You can see different types of epithelium. Oh, exactly. It's lining. It lines all of the tubes. So you can see simple squamous. And you can see cuboidal, simple columnar, stratified squamous, stratified columnar, basically differentiate. Don't worry too much about it now, but basically in all over your body at different tissues you have different type of epithelium. For example, really high yield one, the one that is located at your lower esophagus. It's a stratified squamous epithelium. And in case of Barrett esophagus, it becomes what? Stratified squamous. Becomes what? Becomes simple but not cuboidal. It becomes simple columnar with goblet cells, which is an example of if one cell change to another cells, we call it metaplasia. Yeah. So yeah, that's basically, if we speak about epithelium, it's the lining of your body. So what about mesenchyme? What is mesenchyme? Mesenchyme basically describe other types of tissue. For example, your cartilage, okay? Your bone, your blood, your muscle. All of these are mesenchyme, okay? For example, I cannot say osteocarcinoma. There is no such thing. Osteosarcoma, yeah? Sarcoma. Why? Because it's mesenchyme. I cannot say chondro, which means cartilage, chondrocarcinoma. Chondrosarcoma, because it comes from mesenchyme. Yes? So any tissue that comes from mesenchyme, we give it the word sarcoma. Any tissue that comes from epithelium, we give it the word carcinoma in case of malignant cancer. Okay? I hope it makes sense what is the difference between mesenchyme and epithelium. Okay, let's go back there. So, again, epithelium creates the lining of most of your tubes, while mesenchyme makes the structure themselves, like the bone, the blood, the muscles, and the cartilage. So, renal cell carcinoma, polygonal clear cells. You can see these cells are clear from the inside, and in a moment we will speak why. Is it visible like this, guys? Can you see normally? Okay, good. So it's a polygonal clear cells filled with accumulated lipid and carbohydrate. Well, now comes the question. You are telling me that it's filled with lipid and carbohydrate, but when I look at the picture, it looks empty. Why it looks empty since you said it's filled with lipid and carbohydrate? Let me tell you guys. So yes, exactly. So in renal cell carcinoma, basically it's true. It has these clear cells that are full with what? Lipid and carbohydrate. Guys, if you have alcohol, okay? Well, let's say that you have methanol, you know, the antiseptic. And I take that alcohol and put it on fat. What will happen if I take methanol and pour it onto fat? It will dissolve. Exactly, it will dissolve. It will just like dissolve. And when it dissolves, that basically means it disappeared. Well, during the preparation of the specimen, the histological specimen, this one, we put actually alcohol on the specimen. When you put the alcohol, what happens to the lipid? It dissolves. That's why you have empty spaces. Okay? So yeah, this is renal cell carcinoma, also called clear cell carcinoma. Guys, what is this structure here? Exactly, it's the glomerulus. This structure here is the glomerulus. Good. So this is the glomerulus. This is this area. See, a lot of empty cells. So what is it? A lot of empty cells, clear cell. So this is the, yes, well, the lipid that was dissolved. So which type of cancer is it? Renal cell carcinoma. Remember guys, for the abbreviation of renal cell carcinoma, you just write RCC from now on. So let's take a look. The next one, we have, they say that on pathology, it appears golden yellow due to increased lipid content. This lipid content is going to go with us for multiple diseases. Let's start looking at a gross specimen of cancer of the kidney. It looks yellow. Why it looks yellow? Because it's full with lipid. There's a lot of lipid inside of it, and we were able even to see it in histology. They love to show you this, and they ask, then they ask you, well, what is it? And what they are trying to confuse you with. What other disease we spoke about had yellow discoloration of the kidney? There was one more disease we spoke about that had yellow discoloration of the kidney. Which other disease has yellow discoloration of the kidney because of chronic inflammation? If you remember, yes, exactly. Exactly, good. So we were speaking yesterday, for those who attended, we were speaking about no, actually not yesterday, the day before yesterday, we spoke about different types of UTIs, yes? And after speaking about UTI, I mentioned this pathology, Granulomatous Pyelonephritis. In that pathology, the patient had a lot of granulomas inside of his kidney due to the chronic inflammation of his kidney. Basically, he had a UTI that persisted for a really long time, which led to creation of a granuloma, which contained foamy cells inside of them. Anyway, don't go to the details. If you take a look at a gross specimen of it, let's take a look at the gross specimen. It looks something like this. Yeah, so it has yellow discoloration of it as well. See, it has also yellow discoloration. So you might get it confused with the renal cell carcinoma. The main idea that in this one, there is no masses and it's diffuse. So if it was diffuse, you think about the xanthogranulomatous pyelonephritis. So diffuse, you go with the xanthogranulomatous pyelonephritis. But if it was one area affected, or localized or focal, you will think about renal cell carcinoma. Okay, so moving on, we have, okay, so speaking about renal cell carcinoma, It originates from the BCT, proximal convoluted tubule. This is super important because each of these cancers originated from different places. So if we speak about renal cell carcinoma, it originated from the BCT. Well, if you remember, guys, we spoke about 4 types of cancer that actually they are carcinoma. Okay, before speaking about this, there is something called carcinoma and sarcoma. To start with carcinoma, it's a cancer of epithelial cells or mesenchyme. Write me, please. Okay, epithelial cells. What about sarcoma? Mesenchyme. Good. So if we speak about, in this case, carcinoma, it's a cancer of epithelial cells, like our patient here. Well, epithelial cells, which is carcinoma, the metastasis means movement of the cancer from organ A to organ B, basically movement between the organs. We know that normally, forget about renal cell carcinoma for now, we're speaking now generally, the carcinoma, how they metastasize, how do they move from one organ to other organ? Is it using the lymph or is it using the blood? The carcinoma in general, I'm speaking. Yes, actually it's using the lymph. Okay, it's using the lymph. What about sarcoma in general? Sarcoma, it's hematogenous, so they use the blood. Okay, so there is an exception for these carcinoma. There is 4 exceptions you must know about. So in GIT, I will tell you about something called hepatocellular carcinoma. And in endocrinology, I will tell you about follicular cancer of the thyroid, follicular cancer of the thyroid. And when we study reproductive together, I will speak with you guys about choriocarcinoma, okay? Finally, forget about all of these. Now, today, we are going to speak about renal. And I'm going to repeat this topic 4 times, basically in each system. So the carcinomas will be hematogenous in 4 cases only. Hepatocellular carcinoma, choriocarcinoma, and hepatocellular, and what else here? Follicular cancer of the thyroid. And finally is our pathology for today, renal cell carcinoma. Okay? Well, the question comes, why? Why is renal cell carcinoma is going to the blood and not doing like other ones, you know? So like it's not going through the lymph. So renal cell carcinoma actually like to invade the renal vein, okay? It goes inside of the renal vein. Take a look at this, guys. So basically, take a look. So as you can see here, take a look at this thing. The patient has cancer of his kidney, renal cell carcinoma. It invades the renal vein and enters inside of your renal vein and go up to the superior vena cava. Guys, do you remember which vessel is connecting to your renal vein? So we have the suprarenal, suprarenalis, vena suprarenalis, but we had one other one. What is this? What is this, guys? The gonadal vein, exactly. So it will be obstructed by this cancer. So if it will be obstructed, which symptoms the patient will have? Well, it could be painful, but basically it's a varicocele. Varicocele. Let's take a look at this varicocele. So basically, yep, it looks something like this. See, they will mention it on the exam as a warm bag feeling, okay? Like a bag of worms. And basically, you can see it here. It's due to what? It's due to the congestion of the veins at that area. So they become enlarged, yeah? And here is the thing. In this patient, they can occur only on the left. They cannot occur on the right. They occur only on the left, okay? So the vein obviously is not colicky because this is a vessel, okay? It's a vein. Sometimes it can be completely painless. It's just uncomfortable to have this. And sometimes it can be painful if the congestion was really bad. Most of the time in the exam, because they don't like you guys, they will make it painless. Okay? Yes, they call it bag of worms. Look at this structure, at this plexus. If you feel it with your hand, it will feel like a bag of worms. Yeah? That's how they mention it on the exam. They will tell you, you feel, oh yeah, that feeling. So, okay, well, I will send you this. And yeah, it's difficult to forget. So this is the bag of worms. And you can see here, like you can imagine feeling that, palpating it, and then it feels like a bag of worms. Keep in mind that it's only on the left side. It's only in the left side. So left-sided. Yes, I can. So in this picture, the cancer is basically, let me try to copy this. Okay. Yep, good. So if we take a look at this, you can see the cancer. I'm going to mark it with the color green. So here it is. This is the cancer. And it's invading. Yes, it's invading. And it keeps invading until it's entering the inferior vena cava and even the freaking liver. Yes? After that, notice here, there is one vessel. Let me make that vessel in the color pink. So this is this vessel. Yeah? This vessel will continue downward until it reach what? Yes, it can go all the way till the liver. Yes, that's correct. Until it reaches the testicle, because this is the gonadal vein basically. So this is the gonadal vein. When it reaches, and basically now there is a form of obstruction. So it cannot go upward, so it has to go downward, the blood flow, I mean. So there is a form of a blockage here because of the cancer. So the blood from the testicle cannot be drained. So that convert into a bag of worm. And that bag of worm sensation is pretty specific for this pathology. Okay? Okay. So, moving on. Oh yeah, good. So, moving on, we have the following. It originates from the BCT, invades the renal vein, and after invading the renal vein, it may develop varicocele if left-sided, which now you guys understand. By the way, a really common question on the USMLE, which vein is longer, the left renal vein or the right renal vein? Left renal vein. What they are asking basically, they are asking you normal anatomy. Why the left renal vein is longer? Because it has to go over the aorta and keeps going until it reaches the inferior vena cava. Yeah? So it has to go all the way like this, renal vein. While the right kidney, it has just to go like this, super close to it. So you must also know that for transplant, the donor gives the left kidney or the right kidney? The donor. The left one. Yep, the left one. Okay, good. So, and in the recipient, where do we put the new kidney? Where do we put the new kidney? In the place of the old one, or where do we put it exactly? Yes, exactly. You must master this one. They ask it a lot. So basically the donated kidney is put in the iliac fossa. Why? Because it's less dangerous for the patient, okay? For the recipient. Well, let me send you this picture. And do we keep the previous kidney? Do we keep the diseased kidney? Yes, we keep them because a partially functional kidney is better than zero functional kidney. Okay, so let's take a look here. So they go to the IVC and then they separate hematogeneously. They can metastasize to the lung and to the bone. Let's think about it logically. Well, if they go to the inferior vena cava After going to the inferior vena cava, they will go to where? So let me see this. So they are going to the inferior vena cava. We know that the inferior vena cava, well, it can keep going. Here it can give the hepatic branch to the liver. So it can go to the liver. This is obvious. But also it can continue inside of the inferior vena cava. Basically here they are drawing the IVC behind the liver. But it can give a branch to the liver, you know, the hepatic vein. And you need to know that the portal vein also give to this, but it does, the portal vein is another system, basically. Okay, anyway, so the tumor will keep going and it will reach which portion of your heart? The inferior vena cava, which portion of the heart does it reach? Right atrium, exactly. So it reaches your right atrium, the cancer, and then it reaches the right ventricle of the patient, then goes to the pulmonary trunk, and then metastasizes to which organ is this? Exactly, to the lung. That's why renal cell carcinoma goes to the lung. It's logical. It just moves through the renal vein, inferior vena cava, right heart, and goes straight to the lung. Yes? So no problem in that. So now comes a question, and a really important question. Why the bone? It does not make sense to have the bone. Well, there is something called Batson System. Let me show you the Batson System. They love to ask about it. Batson System, vein. Okay, so, no, just a second. Vertebral. Oh, yeah, they love to ask about everything. Vertebral plexus of veins. Batson, exactly. It's the Batson vertebral plexus. So this Batson vertebral system is basically a type of system. As you can see, it takes, this is your inferior vena cava, yes? So this inferior vena cava is connected to your lung. We established that. But it also can connect to other portions. It has a posterior branches which connect this guy, the Batson system. The Batson system is basically a system that goes to every single vertebra in your body. Okay? So any cancer that can reach the IVC, the inferior vena cava, can go to the Batson system. Okay? So let me send you a picture of the Batson system. Okay, that's the Batson system. You must know it. Because in the future I will be asking you, oh, breast cancer going to the bone. Through what? And you have to tell me it's the Batson system. Okay? So this is the Batson system. Basically, it's a system that connect your inferior and superior vena cava, but indirectly. See, it's kind of like a collateral type of thing. Okay? Through your vertebra. So if it's going through the vertebra, you can imagine logically that it can metastasize to the vertebra. Okay, let's go back to our topic. So it metastasizes to the lung and the bone. I hope you understood that. And it manifests with hematuria. And, well, good question. This hematuria is happening due to cancer of the kidney, okay? Here is the thing about this one. Mostly, and write a note about this, mostly, will it have a cast or not? This is a tricky one. Be careful. It will not. It will not have a cast. Mostly. Mostly, it will have no cast. And this is how they love to trick you guys. It does not have a cast. The second question, which is important, if I look at the RBCs, will they be damaged and dysmorphic, or they will be intact? Well, here's the thing. In this type of cancer, do you have to go through the glomerulus, or the cancer is after the glomerulus? So will the RBCs have to be compressed? If they are not going through the glomerulus, will they be compressed? No. So if they are not compressed, they will not be damaged. That's the thing. So the RBCs will be intact. It's all about these little stupid details that they play with you with these exams. So it manifests with hematuria, palpable masses, well, basically the cancer, and secondary polycythemia. Can somebody tell me why they have polycythemia? Why they have polycythemia? Increased erythropoietin, exactly. So I was asking why they have secondary polycythemia. It's because of increased erythropoietin, and you must know that the erythropoietin normally is produced where? The erythropoietin normally is produced in the interstitial cells of the peritubular capillary, not the liver. So let's see where we saw that actually. Okay, here is erythropoietin. It's made in the peritubular capillary bed in response to hypoxia. Okay, so when we have a production of a hormone from an organ due to a cancer, what do we call that? If a hormone was produced from an organ due to a cancer, how do we call that? We call it Paraneoblastic Syndrome. So the definition of Paraneoblastic Syndrome is a secretion of a if we have a production of a hormone or antibodies or any substance from a tumor that can lead to pathology, we call it Paraneoblastic Syndrome. So, for example, when your kidney now is secreting erythropoietin, yes? Well, your kidney is supposed to secrete erythropoietin, but not that much, not to cause polycythemia. So if it's secreting so much erythropoietin due to the cancer, we call that Paraneoblastic Syndrome, okay? So let's take a look. It's associated, and they write here, polycythemia, flank pain, fever, and weight loss. By the way, on the USMLE, whenever you see weight loss, think cancer. Always think cancer until proven otherwise. Okay, so let's speak about the class triad. They have a flank pain, palpable mass, and hematuria. Most common primary renal malignancy. Let's take a look at it. You can see it like this on a CT scan. Basically, it's irregular, it's wide, but they will not ask you to diagnose something like this just from a CT scan. They must show you a gross picture or tell you symptoms like, for example, this paraneoblastic syndrome with increased erythropoietin synthesis. So, or show you a picture of this, which is the clear cells, and ask you which substance is was inside of it. Which substance used to be inside of the clear cells? Exactly, lipid and carbohydrate. Okay, so if we speak about the if we look at this CT, I will tell you about organs. You will tell me what they are. Which organ is this? Liver. This is the liver. Okay, what about this one? Which organ is this one? No, it's not the adrenal. Yep, it's the spleen. Good. This is kidney. Well, one student will tell me, what is this? What is this? Oh, come on. It's so big. It cannot be the ureter. It's a muscle. And we call it the psoas muscle. You must know about this muscle, psoas muscle. Okay, excellent, good. So moving on. Oh, what about this? What is this? Bladder. What is this behind the bladder? It's behind the bladder. Which organ behind the bladder? The uterus. Excellent. It's the uterus. Yes. And behind the uterus is the rectum. Okay? Good. So you need to know this orientation. The bladder comes first, then we have the uterus, then we have the rectum. Okay, good. So moving on. It's most common in really old people between 50 and 70. And if they ask you why, you must say tobacco smoking. Okay? Tobacco smoking and obesity. So now comes the question, how the hell smoking, you smoked something from your lung, how it's going to your freaking urine? Well, because it was clear to the urine. And there is one point that you actually need to know. It is this one. So they like to ask you about where it is, come to me. Yes. So the tobacco smoking has some substance called naphthalene. This naphthalene can go inside of your blood. Basically, you smoke it, it goes to your lung, it gets absorbed. After it gets absorbed, it goes into your circulation, the naphthalene. After that, you want to clear it outside of your body. Which organ help you to clear substance outside of your body? Which organ help you to clear substance outside of your body? The kidney. Thus, it leads to kidney cancer, the first organ it hits. Okay, let's move on. We have so the next thing they write, it's associated with Paraneoblastic Syndrome, which now you understand what does Paraneoblastic Syndrome. For example, parathyroid hormone related peptide. So this is not a real parathyroid hormone. This is super important point. It's related peptide, which means it looks like, but it's not. It's not the same, guys. Okay. So here they write beer mnemonic, which means parathyroid hormone related peptide. What does the parathyroid hormone do, guys? What does it do for your calcium, for example? Yes, it increases the calcium. What about potassium? Yes, it will be much lower than usual. Where does it work to decrease the potassium? Yes, the BCT. What about the calcium? Where it helped to reabsorb the calcium? Exactly, it's the DCT. Good. So if we speak about the parathyroid related peptide, it works exactly the same, but it does not affect the real PTH. What I mean is, if the patient has parathyroid hormone related peptide, what will happen to his calcium level? Okay, it will be high. It will be high because its parathyroid hormone will be working, so the calcium level goes up. Okay, parathyroid hormone help for the reabsorption of the calcium and also increase the degradation of the bone, which make you basically more calcium. Okay, so if you have more calcium, what is going to happen to your real BTH, parathyroid hormone? What is going to happen to the real BTH? The real BTH will become low. Exactly. So it becomes much lower. So what I'm trying to say that BTH related peptide will lead to what? High calcium. Okay? That high calcium will inhibit. Okay? It will inhibit the real BTH. So yeah, it goes something like this. They will show you these labs and you must give a diagnosis. So the next one is ectopic EPO. Well, that will lead to secondary polycythemia. Guys, what will happen to the hematocrit in case of polycythemia? Okay, it will be high. Exactly. Good. It will be up. So the next thing is ACTH. Well, ACTH is basically a hormone that is normally produced by which organ? Yes, it's normally produced by the pituitary gland. And now it's Paraneoblastic Syndrome, which means that the organ that should not normally secrete that substance is now secreting it. So he will be making ACTH. If it's making ACTH, you will have what? If you have more ACTH, you will have a Cushing-like symptoms. Cushing is a disease that I'm going to explain for you when we do endocrinology. Basically, these patients will have multiple problems. They can become overweight. They have this red striation on their body. They can have this moon faces. They can have the the moon faces can occur. They can have really bad weight gain, and they also can even develop I cannot find it. Yes, this stretch mark. See, they have this stretch mark and thin hair. Okay, so here you go. Here is the thing. If you speak about Cushing syndrome, it's a constellation of symptoms. So if we are speaking exactly about cancer, they will not have that weight gain. You are right, because cancer leads to weight loss. But Cushing syndrome can be due to other disorders. For example, like a primary pituitary tumor. Regardless of the fact that pituitary tumor is a cancer, it will lead to weight gain because the cortisol that it will be produced from the ACTH, ACTH lead to what? More cortisol. So this more cortisol will make you get what? Hyperglycemia, and that will eventually lead you to have more lipids. More lipids make you fat. Yeah? So, okay. So the next one is renin. If this renal cell carcinoma started producing renin, which system will be activated? Exactly, it will be the RAS system. I like the fact that some person just straight up told me hypertension, because that was my next question. Okay, so what will happen because of that? It's hypertension. Yep. Okay, so next we have, the clear cells, most common subtype, which is this one. It's associated with gene deleted on chromosome 3. So renal cell carcinoma is a 3-letter, so it's chromosome 3. It could be sporadic, which means nothing has caused it, it just happened. Or it can be inherited, like in case of von Hippel-Lindau. So you're like, von Hippel what? Von Hippel-Lindau. So what is this von Hippel-Lindau? It's one of these neurologically associated disease, which means that this patient who have von Hippel-Lindau will have both cutaneous and neurological symptoms. So we have a constellation of diseases that we consider to be neurocutaneous diseases. So you have neurofibromatosis, tuberous sclerosis, and all of these ones. One of them is von Hippel-Lindau disease. Now comes the question, why the hell does a disease lead to both neurological symptoms and the cutaneous symptoms? It does not make sense. One disease can lead to neurological symptoms and cutaneous symptoms in the same time. Well, when we do reproductive system, I will tell you about something called the ectoderm. Ectoderm is basically the thing that makes you your what? What does ectoderm makes for us? It makes for us the neurological tube. Notice something. The ectoderm, what does it make for us also? That's surprising. That's actually really cool, I have to say. So, it makes for us the pigment cells, neurons of the brain, and the epidermis skin cells. So in case of neurocutaneous diseases like neurofibromatosis or von Hippel-Lindau, the patient will have neurological problem, like neurological tumor basically. Also, he will have some pigmentation of his skin, like the cafe au lait spots. and also epidermis forms of lesions, okay? Because all of these comes from the same ectoderm. This is for reproductive. I'm just telling you about it now. So here you can see von Hippel-Lindau. It has this something called Harbin mnemonic, in which they will have Hemangioblastoma, which is basically hemi, it means blood. Angio means vessel, okay? So they have this tumor of the vessels. And when they have this tumor of the vessels, it can itself start producing erythropoietin. We'll speak about that later. They also have angiomas, and they also have, here it is, our friend, renal cell carcinoma. So yeah, we'll go back to renal cell carcinoma when we speak about this pathology. Lastly, pheochromocytoma. So let's go back to our renal. Okay, so speaking about this, yeah, it could be associated with von Hippel-Lindau syndrome. Okay, good. So the next tumor I'm going to speak about is the renal oncocytoma. This renal oncocytoma is benign, and this benign cell arises from the collecting duct. Yes? Speaking about renal cell carcinoma, was it benign or malignant, guys? Renal cell carcinoma is benign or malignant? Exactly, it's malignant. And speaking about renal cell carcinoma, which tubule it originated from? Exactly, it was the BCT. Now, this one, the renal oncocytoma, it's originating from the collecting duct. This is super high yield to know, okay? So, and there's like one thing that is super characteristic of, which is basically it has a central scar on a gross examination. I know that this is stupid, but if you guys watched Harry Potter, so that's how I memorized it. Well, I don't know why, but I just took like Harry Potter picture and put it near that cancer. Why? Because he has this scar on his face, you know? And it looks like weird. It looks like this, see? It looks like this. And if you look at the renal oncocytoma gross picture, yep, you can see that it has a scar in the middle. And always it has the scar in the middle that reminds me of Harry Potter. I don't know why, but it does. So they have a scar in the middle, that's oncocytoma. Whenever you see a scar in the middle, that's oncocytoma. Here is the scar. No. Okay, so okay, so it has a scar. So what? Oh yeah, one more. As you can see, it's a benign tumor. It's well circumscribed. Yes, well circumscribed because it's benign. And it's originating from the collecting duct. Okay, good. So here they write also for us that the arrows in A are showing a well circumscribed mass, which means benign, with central scar. Where is the scar? Here it is. Okay. So on histology, you are going to see what? So the renal oncocytoma has a large eosinophilic cells with abundant mitochondria without perinuclear clearing, okay? So they have a lot of mitochondria. And mitochondria actually look eosinophilic, which means it has which color? Eosinophilic? Eosinophilic means pink. This is correct. It looks pink. So in histology, it will be pink, pinkish color. Yeah? Why? Because a lot of mitochondria will be in it. Without perinuclear clearing. You are like, what is this perinuclear clearing? I don't get it. Well, there is another cancer which they put between the lines, and I hate when they do this. They put it between the lines, another cancer that is super high yield, but they put it between the lines that you don't even notice that it exists. There is another cancer called chromophobe renal cell carcinoma. So far we had renal cell carcinoma, renal oncocytoma, and now we have a chromophobe renal cell carcinoma. The only difference between renal oncocytoma and renal cell and the chromophobe renal cell carcinoma, actually two differences. This one is malignant, this one is benign. So carcinoma is malignant, oncocytoma is benign. The second difference is in histology actually. So when you look at it in histology, you will be able to see the following. Okay, so yep. Notice it does not have completely clear cells, it has partially clear cells. So if you take a look at it here, take a note about this one, for example. You have big nuclei. So what is happening to the nuclear cytoplasmatic ratio in this case? Nuclear cytoplasmatic ratio. The nuclear cytoplasmatic ratio, which means the amount of a nucleus compared to the amount of the cell, is increased. You are correct. So this is a sign of what? What? Yeah, it's a sign of cancer. Exactly. Good. So, okay, if we take a look about this one, look, you can see the cells, and around the cells there is this clearing. Yes, it has a clearing. So when the moment you see that clearing, done, you have your diagnosis. Okay, so what's up? Let's see. So the diagnosis here is a chromophobe renal cell carcinoma. So a chromophobe renal cell carcinoma has the perinuclear clearing. And speaking about the renal oncocytoma, it does not have that. So it presents with a baneless hematuria and flank pain. You are like, wait a second, how did you get both of these? How flank pain and baneless hematuria? What they are telling you guys, that these patients, when they are urinating, they do not feel pain. Okay? When they are urinating, actively urinating, zero pain. Okay, so what about if you palpate their flank? Yes, that will be painful. Also, they will have abdominal mass, which is the cancer basically, and it's often resected to exclude malignancy, which is renal cell carcinoma. So yeah, Harry Potter, this renal oncocytoma is not cancer, is not an actual malignant cancer, but you will remove it just in case not to be renal cell carcinoma in the process of development. Okay, so now let's take a break for 10 minutes and we will be back after the break, finish up with the tumors and do the diuretics. See you guys in 10 minutes.